Hey guys, what's up? This is Sean from nursedose.org. Today we're doing a podcast. I'm with my coworker Carlo.
What's up, y'all?
So Carlo and I work together. Carlo, why don't you tell us about yourself?
All right. So first off, I just want to say thanks, man, for letting me be a part of this. Sure. All right. This is the second podcast. Second podcast. So I'm one of the day twos. So a little bit about me and Sean's journey. It's pretty similar. We both, because you had a bachelor's prior to nursing, right?
Right.
Okay, so yeah, that was kind of similar to me. I started off my, I guess you could call career. I originally went to undergrad for dental school, actually. Mm-hmm. So I took my DAT. I don't even remember what score I got. But I even applied to dental school, and then I didn't want to take a year off. Right. So I went on Google. I looked up some places, and UTESCA, it's a school here in Central Texas, offered an accelerated program. So what that entails is you go to school for, I think it's like 17, 15 months. Mm-hmm. And the only requirement other than a prerequisites is you had a degree before that. Right. So I went to that, finished that, and decided to stay here in Central Texas and worked at a private hospital in the medical ICU. Mm-hmm. So yeah.
And how long did you work in the medical ICU?
I did that for about a year and a half. Okay. We saw the ICU we're at right now is the surgical ICU, so we see more obviously post-surgical patients. The medical ICU is a lot more chronic, right? Chronic patients. So we saw a lot of like CHF exacerbations. We saw a lot of acute kidney failure. It's those type of things, and so that was a good experience. But then I said, you know what, I want to switch it up, go to surgical ICU. So then I've been in the surgical ICU for about 2.5 years, and that's where I met Sean.
Right. Yeah. So this is a great segue into today's topic. So you went into the ICU as a new grad, right? I
did, yeah. So listening to your first podcast, kind of similar as well. There was a residency program in this particular hospital I was in. And right off the bat, if you're interested in going into the ICU as a new grad, I think that a lot of it's just based on your personality. Right. Because at whenever they're interviewing you, unless you were like a savant in nursing school and you just absolutely knew everything, they know you don't know a lot of stuff. Right. I think when you come out of nursing school, they know you know enough not to kill someone. All right. So what it comes down to it's like, are you coachable? Right. So right. If you're interested in going to the ICU as a new grad, you got to find a way to just show that you're coachable, that you have a fun personality, and the best way to do that is honestly get hired as a tech. Right. So the new grads we have in our ICU right now, a lot of them, or a majority of them, worked as a tech.
Were you a tech?
I was not a tech, no.
Oh. Yeah. I was a tech before I got into the ICU. And while it didn't do a whole lot for my knowledge for nursing, it helped a whole lot with my time management and actually just being around patients. Because I think a lot of people in nursing school, they only get their experience with patients with clinicals, and I feel like clinicals are a lot different than the real world.
Definitely, yeah. And if anything, you learn how to communicate with patients better. Like when you just come off nursing school, like you just have a very maybe 50 hours of actual right. If you could call it patient care, you're mostly just standing behind. Yeah. You're that person you're shadowing. Yeah. But whenever you're a tech, you kind of get a feel of, what's involved and
right.
with all that.
And when I was in nursing school, I actually had never, like, we had one class on vasopressor medications. So whenever I came to the ICU as a new grad, I had no experience with those kinds of medications. And those, like you know, are very important in the ICU.
Yeah.
So being as far as you are now with your career and looking back and seeing the new grads that we have now, do you still think it's a good idea to come into the ICU as a new grad?
You know, it all depends on the ICU. I think that if our particular ICU, it's a little, I feel like, too fast-paced sometimes for a new grad, especially like post-op day, like when you land an open heart, when you land one of those transplants, it gets a little overwhelming. So I think our ICU we have a very good culture with our ICU. Right. So
like in terms of teamwork?
Exactly. So our ICU, I think sometimes there's a float. Our charge nurse for sure doesn't have a patient most of the time.
Yeah.
So if you're a new grad, go look at the ICU you're interested in. And go over there, shadow them. If you're like, hey, like this team seems pretty good. Right. Give it a shot. Right. Give it a shot. But I think you should expose yourself to an ICU before you even, because I didn't even do a rotation in the ICU whenever I was in Utah. I know. So I was like, you know what? Because at the time I wanted to potentially do CRNA school. Yeah. I was like, hey, that's pretty cool. So let me just jump into the ICU. And my second day in orientation, there was a code already. I'm like, dude, am I like up for this shit? It was scary, but my preceptor was really like, I think he saw the fear in my eyes. Yeah. So he was like, shout out to Mark. He was like, dude, this is, this isn't going to be an everyday thing, but that type of, but it was good for me to be exposed to that,
Getting back, our ICU that we work in now is kind of like paradise when it comes to staffing ratios and stuff like that. Neither one of us has ever been tripled. And it's a policy in our hospital now that ICUs do not get tripled. Even in our trauma ICU, they will single patients with someone who has above a certain BMI, and then they'll even single people with a couple of vasopressor medications. But when I started in the ICU, it was definitely not in an ICU like that. My ICU that I started in, we would triple all the time. I remember being on orientation and kind of close to the end of it, and they just decided to give me the two patients by myself so that my preceptor could actually take an open heart that we were landing. So you really kind of have to shop around and make sure that it's the best for you. Now, I think I turned out okay, but it was certainly very stressful.
Yeah, for sure. And again, let's go back to, if you could get a job as a tech in that particular ICU, that would probably be the best case scenario. Right. And, if you're not lucky enough to become a tech in the ICU, whatever school you go to, I guess really fight for that ICU you want to do your last rotation in. Right. And, if you're lucky enough to get a rotation in the ICU, in our school it was called immersion. I don't know what other schools call it. Yeah. And so you're there for like 4 to 6 weeks, I think. Make sure they remember your name after you leave. There's some students who rotate through our ICU, and I can't for the life of me remember their names. But the ones we did hire, it was, they made an imprint. Right. And the imprint isn't necessarily like, damn, that person's super smart. It was like, do you know what that's someone we could work with.
Yeah, they fit.
Yeah.
Yeah, that's true. And something else that I would say, whenever I interviewed for my first job, I was a tech at a different hospital, but we would get these cards that patients or other nurses would fill out. And I actually kept them all. We could turn them in for movie tickets or whatever, but I kept them all in my portfolio, I guess. And I actually showed that. And it was actually really nice because the residency program that I got into, like I talked about in the last podcast, is very competitive. There were 5 people interviewing for the same ICU job, and that's out of the 200 that actually applied. So little things that you can do like that really help as a new grad. And I can tell you they probably won't look at your grades so much.
Yeah.
So don't put too much worry about that. It's all about the interview, and it's about being personable and being able to show that you know your stuff, and that you're willing to learn. So being a new grad in the ICU, you're really going to have to do your homework. Like, you're out of school now, but you're going to have to actually read. I would do that every week. I would read, and that's how I got my CCRN so early, and eventually how I got my CSC as well. And I know Carlo has his CCRN as well.
And if I could go back in time, actually, because I only really started thinking about taking the CCRN after the medical ICU.
And for those that don't know this, the CCRN is the critical care certification through the AACN, or the American Association of Critical Care Nurses. So just to put that out there.
Yeah, and so when I was in the medical ICU, I guess I was so worked up on trying to like learn everything. I kind of forgot where the most of the learning is outside of work, like you mentioned. So like Sean, just to reiterate what Sean was saying, like it's very important that when you're outside of work that because when you're at work, you're just too stressed out to really take the information in. So when you go outside of work, that's where you really lay the foundation for your knowledge. Right. Like, I think I only really started, lost my train of thought. But still, yes, so right off you don't have to be in ICU for 1 year to start studying for CCRN. Once you're hired, once you're in orientation, dude, open that book, and then things you don't understand, you ask your preceptor. Be like, hey, I don't understand, ABGs. How do I interpret ABGs? How do what type of vent settings? And then with the vasopressors, know what type of receptors they affect.
And so also going back to you, when you work in an ICU as a new grad, not only is you knowing your information important, but you also need to know how to take criticism well. I've seen a lot of new grads that will assume that they know a lot of things, and it's really hard as a new grad to know those things. You've never, you might have intubated somebody before, but knowing the technique and being around people that have actually done it for years is important. And you really don't want to have a cocky attitude coming out of nursing school, because it looks really bad. Asking questions is really good. Some people might think that I get annoyed when people ask me a lot of questions, but I really don't. It actually makes me feel better that they're asking the questions instead of sitting back at their desk and trying to figure it out for themselves, because that's how patients get hurt when questions aren't asked. And that's a big red flag to me if I'm precepting somebody and I feel like they think that they know everything. It's kind of a big red flag to me, and it's something that I'll talk to the educator about. It's something that needs to be addressed immediately.
That's I think Sean hit the point there with, you got to be able to take criticism. If you come in knowing you know everything, that's just, Sean said it was a red flag. It's a red flag for me. I think it's a red flag for a lot of people, because you obviously don't know everything. And, even to this day, like me and Sean, when we're at work, we kind of spitball ideas to each other, and it just reinforces, what you should know. But what a pretty good setup in one of the ICUs, university. What they do is, their new grads, they have to go through the acute care setting first for like 6 or 8 months, and then they train up for the ICU, which I think is a pretty good idea. Especially because by 6 months you should know kind of how the hospital works already, as far as charting, who you need to call. So that stuff, you don't got to worry about whenever you do orient to the ICU is just strictly learning ICU stuff versus like, damn, you know, what do I need to chart? You know, how do I get a hold of radiology? How do I get a hold of this, and that? Like all that's eliminated, and you could just put all your energy to learning the ins and outs of the ICU.
Right. And yeah. What was I going to say? So I know a lot of new grads, I don't know if this is the same for you, but I had a lot of anxiety talking to doctors coming right out of nursing school. And something that I've realized is you don't have to know your stuff to talk to the doctor. Like you don't need all that knowledge. All you need is the ability to relay information correctly. That's what the doctor's for. So, but I will say, and this is the last point that I want to make with new grads, is the difference between starting in a private facility versus a public teaching hospital. So with a teaching hospital, you'll have, especially on nights, you'll have like interns or doctors that are just out of medical school. And they're the ones who are writing your orders, who are taking care of your patients. So a lot of the time it really helps having a experienced nurse there to give recommendations and things like that. I'm not saying that I know more than a doctor, but I've been in these situations more than they have. Mm-hmm. I've dealt with open heart patients. I typically know how we recover them, and I can give suggestions like that versus a medical student who just came out of medical school. Versus a private where it's all, you know, established doctors. You usually don't have any residents with that.
Yeah, and whenever you start off, because I think everyone has that anxiety about talking to doctors. They'll probably get pissed off at you for waking them up, but like never take it personally. You know, like just know like, hey man, I'm super annoyed when I get woken up in the middle of the night, but in the end of the day, they know they're doing their job. Yeah. And then you just need to know that you're doing your job.
And you know, they are getting paid to sleep, so do not feel bad about waking them up because sometimes they need to earn that money.
Yeah.
But yeah, so I think the next topic that we wanted to speak on was how nurses are portrayed in TV shows, in the media, and kind of like what the reality is. So Carla, what is your opinion? What do you think? How are nurses portrayed like in shows and stuff?
And so I think the most frustrating thing for me, and I guess it's definitely an ego thing, is whenever I tell someone like, hey, you know, like, hey, I'm a nurse, and they're like, oh, so you just like, you know, give meds all day. And I'm just like, there's so much more to that.
Right.
You know, and I think the TV shows kind of try to portray that also. You know, there's, I don't know is there even a TV show where the nurse is like the main.
Yeah,
I guess Nurse Jackie, but that was a kind of a dark show.
Yeah, but you know, honestly, Nurse Jackie's probably probably the most accurate when it comes to what nurses actually do, because those nurse doctor relationships are actually pretty accurate.
Yeah.
But like I can tell you, like in shows like House or Grey's Anatomy, the nurses tend to be like pushovers, right? So. They don't really, it doesn't seem like they do much. Like, yes, whenever the patient starts crashing, they run in there and it looks like they're just fixing the bed sheets or something. They're not really doing anything. But in reality, what happens is the nurses are usually the first ones there before the doctors even get there. So if your doctor is the one who's finding your patient unresponsive or whatever, then you have a problem. So we are usually the first responders. We usually are the ones. So both me and Carlo are ACLS certified. So we can actually run a code by ourselves without a doctor. I don't think a lot of people know that. So we can order medications to be given, and we can follow algorithms to allow a patient to be resuscitated. And so with that, we had a scenario once where we had a patient that went into SVT, and the patient actually lost a pulse And so we brought in the crash cart and actually defibrillated the patient. Of course, we synced and everything. Everything was correct. And we were able to bring that patient back to a stable heart rate that actually allowed him to have a blood pressure. Of course, the resident got a little upset about that and wanted us to call him. Yeah. But we don't have time to, make phone calls when your patient does not have a pulse. Yeah. So what I'm trying to get with that is that there is a lot of things that nurses do that I guess the general public don't really see. And I guess it's more like ICU nurses. Floor nurses as well do the same thing, but it doesn't happen as much. Yeah. They are certainly capable. A lot of them are ACLS certified as well. But in the ICU, we tend to have a lot of autonomy and a lot of input when it comes to what patient care should be. Especially in the private setting. Like, I don't know how it was for you whenever you're in a private hospital, but when I was in the medical ICU, and the intensivist had to manage like 3 different hospitals. So there was times where it was just the nurses running the code, and if we did have any questions, we would just text the intensivist like, hey dude, this is happening, blah 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 blah. And they'll give us recommendations about what to do, but that those codes are run by us. It's a little different now in a community hospital because there's always a resident or an intern in-house, so they kind of jump in and kind of help us out. Right. But I think it's important to for the public to know that we do a little bit more than what the shows portray. Right. And yeah. Yeah, so it's a lot more than just giving medications. There's a lot of critical thinking involved. You gotta know how to work around things, and you have to know your stuff. Like for our floor, we do a lot of cardiac stuff, so we have to know our rhythms. We have to know what to do for different rhythms, what medications work for what and what doesn't. And because we get a lot of people that come through, a lot of interns that come through who are not looking to be, cardiologists or CT surgeons or transplant surgeons or anything like that. So we have to be able to tell them what's going on and give recommendations on what we think should be done. Yeah. So there's that. But yeah, and not to speak ill of residents either. Like I understand where they're coming from, especially it's July. So there's a lot of new interns who just come out of medical school, and I'm pretty sure not a lot of hand-to-hand, not a lot of patient care goes on. Probably a little bit more than nursing school, but it's just put that in the back of your mind whenever if you do work in a community hospital with residents and interns. Understand that, dude, they're just as scared as you were when you first started off. Right. And sometimes they just need a little bit of, you just gotta give them some recommendations. Show them some love also. Right. All right. And if there are any residents or interns that are listening to this, utilize your nurses. Your nurses are the ones who are at bedside 24/7. So don't be afraid to ask them for their input. It might be bad input, but that's your job to discern what you should listen to and what you shouldn't. But a lot of these nurses have a lot of experience with these specific patients, and they can really help you out. But yeah, you have anything else to add to that subject? What TV shows you watch, man? I don't have cable now, but there's actually a TV show that is based on the hospital that we work at. Oh yeah, I heard about that. Yeah, but is it really? Yeah, is it? It's not real footage, right? Of like, no, that's what I was like. I was like, wait. No, it's basically like a mixture between Grey's Anatomy and probably Scrubs, but that one actually does a pretty good job with portraying nurses actually. They wear maroon scrubs for whatever reason, but
What's the show called?
It's called Night Shift. Yeah. Which I think one of our next podcasts is going to be what it's like working night shift, because both Carlo and I work night shift. It's the best shift to work. You get more money, you get more autonomy. Yeah. All that stuff. So just a little preview. But if you don't have anything else to add, Carlo, I think
we're good, dude.
I think that's pretty much it. So thank you everybody for listening this week. We're going to try to do maybe weekly podcasts.
Yeah. If you guys have any recommendations, or so our podcast, we're both nurses, but we're totally down to have, other professions. If you know an RT, or a physical therapist or a resident or intern, and they might be interested in kind of just coming in and just hanging out with us and just talking to shit, then let us know. And if you have any topics that you want to hear our opinions about, let us know also.
Yeah. And so, guys, if you want to keep up with the podcast or the articles that are written on the website, go to www.nursedose.org. I'm going to try to get this podcast on Spotify, so I will make a post about that when that happens, but be sure to subscribe to it so that you don't miss any episodes. Other than that, I think we're done, so thank you for listening. This is Sean and Carlo.
What's up, y'all? Bye, y'all.
And we'll talk to y'all soon. Okay, bye.